Hello, everyone. Thank you for joining us today for our webinar on ER Billing 101. Let me start by introducing myself. My name is Maral Sanassian, and I am the Director of Client Success at DoctorCare. Tailored for emergency room and specialist physicians, Trillium brings over 35 years of hands-on experience helping hundreds of physicians and groups manage their billings. In 2023, Trillium joined forces with us at DoctorCare to expand our support of Ontario specialist physicians and ensure that they are properly compensated for their care. DoctorCare is the largest billing and practice support provider for over 2,500 physicians across Canada. Our solutions and services are designed to help doctors maximize their revenue, improve patient care, and grow their practice. So that you all know, all attendees are in listen-only mode today. We are recording this webinar to make it available to you after the event. If you have any questions during the webinar, please submit them using the Q&A feature, and we will try our best to answer them during this session. You are also welcome to send us any questions you may have to contact@trilliummedicalbillingagency.ca after the webinar. In today's webinar, we will be delving into the world of ER billing, providing a comprehensive overview of the different payment models available for physicians and the essential codes used in a hospital emergency room setting. We will begin by providing an overview of the fee-for-service and alternate funding arrangements payment models. Then, we will dive into the various ER assessments, procedures, and critical care codes. After that, we will offer insights into special visit premiums. Lastly, we will discuss best practices and common pitfalls with ER billing. We will conclude the webinar with a Q&A session, and stay tuned until the end for an exclusive promotion. Before we dive in, let's do a quick overview of ER medical billing in Ontario. Healthcare providers operate within the OHIP framework to bill for the services that they provide. When addressing the intricacies of medical billing in the emergency room setting, where physicians are faced with urgent cases and the unpredictable nature of emergencies, the complexity of billing procedures becomes significantly heightened. Healthcare professionals must have a comprehensive grasp of the payment structures, complex coding systems, and rules governing billing practices to ensure the accuracy of compensation and the ethical integrity of their billing processes. In Ontario, there are two distinct payment models accessible to physicians operating within the emergency department. The conventional fee-for-service model, where compensation is directly tied to the quantity and nature of services rendered, and the alternative funding arrangements, which encompass reimbursement methods created to incentivize quality care delivery to patients, promote efficiency, and be able to accommodate diverse practice models, which we will delve into more in the next few slides. So why was the AFA model introduced? The AFA model was created to ensure adequate compensation for ER doctors, particularly in less serviced areas like Northern Ontario, where patient volume per shift could be low, making it financially unviable for doctors to work on a per-service basis. An hourly rate compensation model was introduced under the AFA, ensuring that doctors are compensated regardless of patient volume, making it worthwhile to work in these areas. Under the AFA model, payments are made to a group of physicians or the ER department, with the group's financial officer distributing the funds. This includes a base hourly rate, which is decided on by the group, plus 38% of the fee submitted through OHIP, allowing for fair compensation across different shifts and times. Physicians also receive 100% of WSIB and out-of-province claims. Doctors who prefer to take their time with patients and are less concerned about maximizing the number of billed services may prefer ERs operating under the AFA. Conversely, doctors who thrive in a high-volume, fast-paced environment and aim to maximize earnings through the volume of billed services may prefer ERs that use the fee-for-service model. Transitioning between the AFA and fee-for-service can be complex, involving adjustments in billing practices, physician workflows, and potentially patient care strategies. Departments need to consider the benefits of each model, including factors like patient volume, staffing needs, and financial sustainability. As we mentioned, doctors may choose ERs based on the payment model, the AFA versus FFS, that aligns with their work preferences. When deciding on which payment model works best for you, it is important to go through the advantages and disadvantages of each. With the AFA model, you can focus more on patient care, as AFA allows physicians to spend more time with each patient, focusing on quality rather than quantity. This model is best suited for physicians who work efficiently at a slower pace. With less emphasis on individual billing, the AFA model also allows physicians to dedicate more time to clinical administrative duties. While the AFA payment model has its advantages, it also presents some challenges. One of the difficulties is determining fair compensation for all members of the group. The whole group must agree on an hourly rate for different days of the week and times of day, which can be tricky. It is essential to find a rate that meets everyone's needs and requirements. When it comes to the fee-for-service model, physicians are directly compensated for every service they deliver, which rewards efficiency and volume. This model is best suited for physicians who work efficiently at a fast pace. Another advantage is that there is clear, itemized billing that makes it easier for physicians to track services that they provide and the corresponding payments. On the other hand, one of the main difficulties when it comes to fee-for-service is that the model may incentivize quantity over quality, potentially leading to unnecessary tests or procedures. Physicians may spend a significant time on paperwork, which detracts from patient care and can be time-consuming. When choosing the model that works best for you, it is important to weigh both the advantages and disadvantages of the AFA and FFS models. If you have any questions regarding the AFA model, please don't hesitate to contact our Trillium team at contact@trilliummedicalbillingagency.ca. To better illustrate the AFA model, let's use an example. Here, we have Hospital X, which currently operates under an AFA model. Years ago, doctors at Hospital X had been having issues with the fee-for-service model while operating in a small town in Ontario, and decided the AFA model was a better fit for the doctors. This transition from fee-for-service to AFA was motivated by the need to ensure compensation for the ER doctors working there, where patient volume per shift was low, making it financially unviable for doctors to work on a per-service basis. The group at Hospital X decided on a rate at which physicians would be paid hourly, based on the day of the week and time of day. The funds are then dispersed to the finance departments and then dispersed to the doctors. The billing department would then let doctors know the amount they are receiving from OHIP claims based on their remittance advice statements. If you have any questions about the AFA model, our team is a great resource. Let's begin this section by introducing some of the most common ER billing codes. Some of the most common codes billed in the ER are the H prefix assessments, which include comprehensive, intermediate, minor, and multiple systems assessments. Like the A codes that general practitioners use for billing for their services, ER physicians use the H codes when assessing a patient. Let's use the weekday daytime assessment codes as an example. The H101 is a minor assessment of a patient, equivalent to the A001. Although an uncommon code, you would use this code when performing a minor patient evaluation. The H102 is an assessment conducted in an emergency department or hospital urgent care clinic that requires a complete history, a complete physical examination, and intermittent attendance on the patient over many hours as required by the patient's condition and an ongoing evaluation of response to treatment. The H103 code is for multiple systems assessments, similar to the A007 in family practice, but adjusted for emergencies. The H103 includes a detailed history and examination of more than one system, part, or region. Lastly, the H104 is a reassessment in an emergency department or hospital urgent care clinic at least 2 hours after the original assessment or reassessment, which indicates that further care and investigation are required and performed. In addition to the daytime codes, let's look at the most common after hours, weekends, and holiday codes. As you can see in this table, the H assessment codes change based on the time of day the service is provided. For example, if you are working on a holiday, overnight, or weekend, the fee for the same assessment, whether it is comprehensive or minor, will be higher on those days versus a weekday. Moreover, more complex assessments that require more work, such as a comprehensive assessment or multiple systems, will pay out more than a minor or reassessment. A common error that physicians sometimes run into is billing a weekend and holiday assessment on a weekday, or vice versa, resulting in a V4 error code. We see this mistake frequently, often resulting in significant financial losses for doctors. With our doctors, we are able to reconcile this error when it comes through and resubmit the claim appropriately, so the doctor does not lose out nor delay their payment. If you are a physician who struggles to get errors reconciled and resubmitted, contact us today to learn more about our error reconciliation service. In the ER, doctors not only provide assessments, but provide consultations to patients as well. A consultation is a medical assessment a physician provides upon a request from a referring healthcare provider, such as a physician or nurse practitioner. The referring provider requests the opinion of a physician who is competent to provide advice in a specific field. This request is usually made due to the complexity, seriousness, or obscurity of the case, or because the patient or their representative has requested another opinion. In the hospital emergency department, physicians would use either the H055 or H065 code to bill for a consultation, depending on their specialty. If you are a general practitioner working in the emergency department, you would bill the H065 code, which is similar to the A005 family physicians bill in their practice. If you are an emergency medicine specialist, you would bill the H055. Let's take a look at this example. A doctor with an emergency medicine specialty sees a patient in the ER for a consultation regarding a broken leg. What code would they bill for the consultation? Because the physician providing the consultation is an emergency medicine specialist, they would bill the H055. Now, let's take a look at procedure codes. As you know, in the emergency room, physicians are responsible for more than just assessing a patient's condition. They must also perform various medical procedures like sutures, foreign body removal, and fractures, dislocations, treatments. It is worth noting that ER physicians receive only 75% of the fee when it comes to fracture treatment, while orthopedic surgeons receive 100%. We have listed some of the typical procedure codes on this slide, and We also have a comprehensive ER billing sheet that includes all the medical procedure codes that we will share with you after the webinar. Now, let's look at the procedure premiums available for ER doctors. When a physician performs a procedure outside of regular business hours, such as in the evening, on weekends, or during holidays, they can add a premium code to the service. This premium code adds an additional fee to the procedure cost, depending on when it is performed. For instance, the E412 is added to the procedures done in the evening, on weekends, or during holidays, and it pays an additional 20% of the service fee. Meanwhile, the E413 is added to the procedure performed overnight, which pays an additional 40% of the fee value. We created a guide that will provide you with key information on how to bill the after-hours procedure premiums, and we'll provide a link after the webinar. Moving on to anesthesia. Some procedures require anesthesia, whether it is local or general. Note that only specific procedures are eligible for anesthesia units, and you can refer to our ER billing guide for the full list. You can see a section on this slide, taken from our ER billing sheet, that shows you how to bill for anesthesia units. You will bill the procedure code with the C suffix and add the time units. If the procedure was done overnight, you would add the E401C, which is the anesthesia premium. If the procedure was done in the evening or the weekend, add the E400C. Based on the table, if the patient falls between a certain age bracket or a specific situation, you would be eligible for extra units on top of the basic units. We will now look at different critical care codes. If a physician is not performing assessments in the ER, they are probably performing critical care. Critical care codes are categorized as either life-threatening or resuscitation. Life-threatening critical care are services rendered when a physician provides critical care to a critically ill or critically injured patient who has acutely impaired one or more vital organ systems, causing vital organ failure. You would bill the G521 for the first 15 minutes of performing critical care, valued at the highest fee of $111.80. After that, you would bill the G523 for the second 15 minutes and the G522 for an additional 15 minutes to a maximum of 4 units. It is important to note that the G521 can be billed by up to 3 physicians for the same patient on the same day. If a 4th physician wants to bill it, they would need to bill for the lesser fee, the G395 code. Resuscitative critical care is defined as a service rendered when a physician provides resuscitation assessment and procedures in an emergency setting in the circumstances other than those described as life-threatening critical care, where there is a potential threat to life or a high probability the patient will suffer loss of limb or require life-threatening care. To bill for resuscitative care, you would bill the G395 code for the first 15 minutes and the G391 for an additional 15 minutes to a maximum of 8 units. Please note that the G395 can be billed by up to 3 physicians. The most common error physicians see are M4 errors, which come back if the maximums have been exceeded. Our team at Doctor Care works with physicians to correct these errors and make sure that they are being paid for these claims. Recently, the ministry has been cracking down on these codes' misuse and requiring more physicians to submit their notes for manual review. Since the submission deadline has gone down from 6 months to 3 months, physicians would need to provide patient notes much quicker to avoid loss of payment. If you need help with error correction and claim resubmission, we have an exclusive offer for you that we will share at the end of this session. Like the ER procedure codes we discussed in the previous slides, certain premiums can be added when billing for critical care procedures. If a physician provides critical care services, or any service other than an assessment during the weekends, holidays, or overnight, you can include the H112 or the H113 to the claim. In our experience, not many physicians realize that they can bill both an assessment or consult and critical care in the same visit for the same patient. However, the only scenario this is allowed is when the patient has come in for an assessment, but ends up needing critical care that same day. This claim can only be paid through a manual review, specifying the time seen for each visit. It is also important to note that for the claim to be paid, the consultation or assessment must be completed before providing critical care. In addition, critical care codes are not eligible for payment with the H102 comprehensive assessment. To be eligible for payment for critical care, the H102 would need to be changed to an intermediate assessment H103. Let's take a look at an example. A patient is sent to the ER by their GP for a headache. The ER doctor bills the ER consult code, the H065, at 9 a.m. They then leave the patient to attend to another patient. The doctor is then called back 30 minutes later at 9:30 because the patient is having a seizure. The doctor would then bill the G521. Both visits are payable, but you would need to send the claim as a manual review. It is important to note that if the patient came in for critical care, the assessment is already included with the G codes and is not eligible for a separate claim. If the physician saw the patient again for some reason, they would bill an additional unit of the G521 or the G395. Doctors working in the ER commonly bill for ambulance transfers. Detention in ambulance is a service payable for constant attendance, providing all aspects of care to the patient in an ambulance. The service includes an initial examination and ongoing monitoring of the patient's condition and all interventions, except when the schedule of benefits provides for separate or additional payments for the intervention. These codes include the K101, ground ambulance transfer with patient per quarter, the K133, ambulance transfer with patient per quarter hour, and the K112, a return trip without patient to place of origin following air or ground ambulance. Some additional codes that are important for ER physicians to know are the H105 interim admission orders, which are payable to the ER physician on call for writing inpatient interim admission orders, pending admission of a non-elective patient by the most responsible provider, and the H100, the ER ultrasound. In a situation where the patient feels better in a few hours and doesn't end up being admitted, the H105 code will not be paid out. Now, let's shift our focus to special visit premiums. It is well known that these codes are among the most confusing for ER physicians, leading to frequent errors and missed opportunities. Special visit premiums are additional fee codes, compensating physicians for unscheduled visits, providing care outside regular hours, or for attending to different departments within a hospital. It is a visit initiated by the patient to render a non-elective service, or if rendered in the patient's home, a non-elective or elective service. These premiums ensure patients receive necessary care promptly, regardless of the timing and location. Be aware that times must be recorded on the patient's record when billing special visit premiums. One of the most common mistakes we see with our physicians is using the wrong premiums for a specific time or date. Beyond this, they often forget to add them into their claims altogether, effectively leaving money on the table. In general, there are certain limitations when it comes to billing special visit premiums. Most importantly, it cannot be billed when a physician does scheduled rounds at a hospital or long-term care institution, including a nursing home or home for the aged. Billing special visit premiums during scheduled rounds will lead to the DF error on your RA. DF errors occur when a specific code is not allowed to be billed with other codes based on their payment rules. In the ER department, special visit premiums are not eligible for payment with services described by the emergency department age prefix codes we described earlier that consider the time of day. This includes the H102, H133, and so on. We'll look at the situations in which ER physicians can bill special visit premiums in the next few slides. To better understand how to bill special visit premiums, you should be familiar with their components. There are 3 different add-on codes that doctors can claim when they are seeing a patient during a non-elective visit. A travel premium, which is only eligible for payment when a doctor is traveling from one location to another, excluding travel that is within the same hospital, long-term care facility, or buildings situated on the same hospital campus. The doctor would have to be away from these locations and be called to them to be able to bill travel premiums. A first person seen premium, which is eligible for payment for the first person seen at the destination, and where a travel premium is also eligible for payment. Lastly, additional person seen, which is eligible for patients after the first person seen has been billed. All of these components have a maximum that a physician can bill in a day, and those maximums differ between the locations a doctor is in. Additionally, the first and additional person seen premiums are only eligible for payment if the service is performed in specific circumstances, described as the eligible times in the schedule of benefits. These include evenings, which is 5 p.m. to midnight, Monday to Friday, daytime or evenings on Saturdays, Sundays, and holidays, or nights, which is considered midnight to 7 a.m. If rendered, requiring sacrifice of office hours, or if rendered during daytime hours, 7 a.m. to 5 p.m. Monday through Friday, in circumstances in which a travel premium is eligible for payment. Note that only one travel premium is eligible for payment for each separate trip to a destination, regardless of the number of patients seen in association with each trip. Let's dive into the different special visit premiums in more detail. A doctor would look at 2 main tables of special visit premiums when billing them for their patients: the emergency department by emergency department physicians, or as we like to call them, the on-call H prefix special visit premiums, and emergency department or K prefix special visit premiums. For this instance, these H prefix special visit premiums can only be used when a doctor is on call. They were either called in earlier than the start of their shift to see patients, asked to stay past the end of their shift to see patients, or travel to the outpatient department. The value of the codes varies by the day of the week and the time of the day the doctor sees the patients. Note that these premiums can be added with the E412, E413 procedure premiums if the doctor is performing a procedure during the visit. Let's look at some examples where the H prefix premiums would be applicable. A physician is scheduled to see patients on Thursday during the day for a shift from 8 a.m. to 4 p.m. However, is asked to come an hour earlier at 7 a.m. and see 5 patients before 8 a.m. What code does the physician bill? For the hour before their shift starts, the doctor can bill an assessment code, for example, the A007, plus a travel premium, the H960, since they traveled to the hospital to see patients before their scheduled shift, and a first person seen for the first patient, the H980. For the second, third, fourth, and fifth patient seen, they can bill an assessment code plus the additional patient seen code, which is the H981. In this situation, the physician is considered on call. In this example, the doctor can only bill one travel premium since they only travel to the hospital once. If the doctor sees more than 5 patients before their shift starts, they can no longer use special visit premiums and must revert to the H prefix assessment codes, so the H102, H103, etc., since they are maxed out. The physician can only bill these special visit premiums in the time before their scheduled shift starts or after their scheduled shift ends. Even if the doctor sees 4 patients before their shift starts and hasn't maxed out on the premiums, once it hits 8 a.m., they can no longer bill the premiums. Here's another example. A physician is scheduled to see patients on a Thursday for a night shift starting at 12 a.m., but is asked to come an hour earlier at 11 p.m. and see patients. What codes would the physician bill? They start the evening with billing their assessments with the special visit premium codes H962, H984, and H985, and then switch to ER evening assessment codes once the maximums have been reached. Then after midnight, they would continue with their ER assessment codes. However, according to the ministry, there is a catch that is not in the schedule of benefits. During the COVID pandemic, physicians were allowed to bill special visit premiums past the time their shift started. For example, if the doctor's shift started at midnight, but was asked to come an hour early at 11 p.m., and there were many patients waiting, doctors were able to see those unscheduled patients past their shift time at midnight and switch to the overnight premiums at 12 a.m., which is a higher value until all of the patients that were waiting, were seen. The doctor would then switch back to H prefix emergency assessment codes. Prior to this, physicians were not allowed to bill special visit premiums past their scheduled shift time. But because of the pandemic, there would have been patients waiting much prior. The overnight special visit premiums have no maximums. This rule is still valid until further notice from the ministry. If a physician gets called to another department, they can use special visit premium codes from the appropriate table in the Schedule of Benefits General Preamble 70 to 78, so GP 70 to 78, remembering that no travel premium can be billed. If a physician gets called to an outpatient department, they will use the hospital outpatient department table, the U prefix premiums. Alternatively, if the doctor gets called to the inpatient department, they will bill from the hospital inpatient table, the C prefix premiums. And if a doctor gets called to the parking lot, they will use the table named Other for non-professional settings that are not listed, which is the Q prefix premium. Another set of special visit premiums is applicable in the situation where the doctor is not at the hospital and is at home or any location other than the hospital. They are considered not on call as they don't have a shift scheduled that day. If a doctor gets called to the emergency department and sees patients, they can bill the K prefix special visit premiums under the emergency department table. Let's look at another example. A physician not scheduled to work gets called into the hospital on a Monday at 12 p.m. to see a few patients. What does the physician bill? They would bill the assessment code, for example, the A003, first person seen premium, the K990, and traveler premium, K960. Due to the maximums, if the doctor sees more than 5 patients, they would revert to the regular H prefix assessment codes. Let's review some common errors and best practices surrounding ER billing that will help you minimize billing errors. For physicians working in fast-paced ER departments, managing OHIP billing on their own can be very challenging. Without optimizing this process, there is a high chance that your claims will result in errors and potential financial losses. The first common error that we see physicians often make is adding more than one travel premium throughout their shift when they did not leave the hospital. Remember, travel premiums can only be used when a doctor travels to the hospital. The second error we often see is confusing travel premium codes with the first person seen premium codes. By educating yourself on the billing rules for special visit premiums and always having the K special visit premium table or the H special visit premium table on hand will help reduce billing errors that may come through. The third error we see is using the wrong table when billing codes and relying on memory. Always have both the K special visit premium table or the H special visit premium table on hand to avoid these billing errors. The fourth common error is not switching to ER codes after reaching the maximum of special visit premiums. This will commonly lead to MD errors on the remittance report. Knowing the maximum number of the special visit premiums you are eligible to bill will help you reduce these errors and maximize revenue. Lastly, the fifth error is physicians billing travel premiums with additional person seen codes. Unless you leave the hospital and return after seeing each patient, which is very uncommon, the travel premiums can only be billed once with the first person seen code. All in all, special visit premiums play a crucial role in the healthcare system by ensuring physicians are compensated for providing urgent and necessary care outside regular hours or locations. Understanding these premiums helps physicians navigate billing practices effectively, ensuring they are fairly remunerated for their services. As we arrive at the end of this webinar, let's go through some key takeaways for today. First, there are 2 available payment models for physicians working in the ER or plan on working in the ER, the AFA and FFS. When choosing the best model for you, it is essential to identify the advantages and disadvantages of both the AFA and FFS models. Understanding special visit premiums and how they work will greatly help you as a physician to reduce billing errors and avoid delays in payment from OHIP. This is where doctors are missing revenue opportunities the most. Moreover, knowing the most common pitfalls when billing these codes will help you avoid rejections and maximize your revenue opportunities. Lastly, please remember, we are here to help. We offer a broad range of services, including practice optimization, billing support, and error correction. Each of you is unique, and we take the time to provide a product and service specifically tailored to your needs. Rest assured, when you work with our Trillium team, you will always have a dedicated resource available to support you and address any concerns you may have. Before we proceed to the Q&A part of our webinar and answer your questions, we wanted to extend an exclusive offer to thank you all for attending. For a limited time, we invite you to book a complimentary billing consultation with one of our expert team members, where we will review your medical billings to identify challenge areas and opportunities for improving your processes. You can contact us at contact@trilliummedicalbillingagency.ca to book your consultation. Now, let's move on to some questions from the attendees. If you have any questions that you would like to ask, please submit them in the Q&A feature in the Zoom console. I will just give everyone a minute to type out their questions. So we have a question with regards to whether we bill at the individual or group level. So we actually do both. So if your emergency department is an alternate funding arrangement set up, then our client, then the ER itself, the department is our client, and we will bill for every doctor in your ER department. If your ER is a fee-for-service model, then individual doctors are responsible for their own billing. So we call these clients solo clients, and in this case, the physician is our client. There are pros and cons to being AFA and fee-for-service, as we discussed, and it is a decision that the ER makes as a group. The more clients we have in any given group or ER department, the easier it is on everyone, as we do have greater visibility throughout the ER. We have a question with regards to the physician does not use an EMR and they submit their billings on day sheets. So can we work with this type of billing? So absolutely. We do ask our physicians to submit their billing sheets to us in a timely manner. That's what's most important. Weekly is best, unless of course you have time-sensitive codes. We generally prefer email, as it is the fastest way to intake your sheets and get them to your billing agent as securely as possible. However, at this time, we do have fax, mail, and courier as options as well. That can be discussed on a case-to-case basis. If you do send us original through the mail or through drop-off, you can request that those be returned to you or made available for pickup. Otherwise, we will securely shred any printed copies we receive after 3 months. So for those of you that have a lot of errors and whether we can help, that is an area of expertise for us. We reconcile every rejection we receive from the ministry from both your error reports and your remittance advice. So most of this is done automatically with minimal involvement of you, the doctor. However, we will reach out to you if we need supporting documentation or if any resubmission requires your input, such as a change of code, for example. So with regards to manual reviews for claims, like if you have a lot of them and what the timeline is like, do doctors still have 6 months to submit them? Is it 3 months with the new changes? So we do have 3 months from the date of service to submit a claim for the first time, manual review or not. The goal is to get it onto an RA before it becomes stale. Once the claim is on an RA, we have 7 months to submit an inquiry for the first time. If we have evidence that we originally submitted a claim within the 3-month window, but now the claim has become stale before getting it onto an RA, so as in the case, for example, it's bounced back on an error report and it's too stale to be resubmitted, then we may have options for submitting them to the ministry as a stale claim. So this is a lot of extra work and could require an additional service fee. So we typically encourage our clients to submit their work as regularly as possible to avoid having to access this service. And then since we're just past time, one final question with regards to our resources and what we've got for ER billing. So on our Doctor Care website, we have a whole library of blogs and guides to help our physicians. We recently created a handy ER billing cheat sheet for ER physicians, which is available for download on our website. Additionally, you can send your billing questions to contact@trilliummedicalbillingagency.ca and our team will answer them. Additionally, our Trillium Plus service values and encourages a close working relationship of trust between you, our client, and our billing agents. It is in everyone's best interest that we all learn how to maximize your billings for optimal financial compensation. If your agent notices that you are consistently billing something that they are having to correct, such as the wrong procedure premiums, the special visit premiums, number of units on assessments, then they do reach out to loop you in on the ongoing issue. That is the end of our webinar. On behalf of Dr. Care and our Trillium team, thank you all for joining us today. If you have any questions or have feedback on this webinar, please feel free to contact us at any time. I hope you all have a wonderful day.